people will not succumb to the postprandial lull. And I'm usually, and I have to apologize, I'm on service this month, so I had to buzz in and buzz out, and I'm usually more social than this. But I'll try to be as social as I can while I'm here. I want to just talk 2 slides about diagnosis and what's different in APS-1 potentially. So, a first morning set of labs is really useful. And most of the time you get your answer just from doing this without any dynamic testing. And a cortisol less than 4 micrograms per deciliter, about less than about 100 is not normal. So why do we measure it in the morning? Cortisol, and we'll talk about this repeatedly when we talk about treatment, cortisol has a circadian rhythm. It's high in the morning and it's low at night. So a normal cortisol at 1 o'clock in the morning is like 0, okay? And so you don't need cortisol then. In fact, it's bad for you at that time of day. And that's what people with Cushing's disease have. So in endocrinology, if you think it's low, you measure it when it should be high, all right? And if it's low, then it's really low. It's not just randomly low at that time. So, and now with the modern assays, about 14 micrograms per deciliter or about 400 nanomoles per liter is normal. Now, what if it's afternoon? Well, you can do a workaround with this, and some of you may have heard people doing this, is you can measure a second steroid that the adrenal makes under ACTH stimulation. It's called dehydroepiandrosterone sulfate. We all call it DHEAS. And if it's normal, then you really can't have any form of adrenal insufficiency. So let's say the cortisol is low. Then the ACTH, which is the pituitary hormone that stimulates the adrenals, it works like a thermostat. So, if it's cold outside, thermostat senses that, kicks in, starts the heater. When the heat comes up, thermostat recognizes that and shuts off the heater so you don't make too much heat. So if the cortisol is low, the pituitary should sense that and make a lot of ACTH, try to get the adrenals to make it. But if the filter in the heater's clogged, you're still not going to get any heat, all right? So if the adrenals are not working, you're not going to make any cortisol. So if the ACTH is low, that means there's something wrong upstairs. But if the ACTH is high, that's what you have in adrenal insufficiency. And then the adrenals make another very important hormone called aldosterone. And it's mainly controlled by a different axis that comes not from the pituitary, but from the kidney. The kidney senses your blood volume. Okay, and volume is an important concept. When your volume is high, you have hypertension and edema. When your volume is low, you have low blood pressure. And that's sort of a component of the adrenal crisis. And so when your volume is low, the kidney tells the adrenals by making a hormone called renin to make more aldosterone. And if the adrenals aren't responding, then that's what you get in adrenal insufficiency. Now, we can always do a cosentropin or I'm actually not sure what they call it in Canada, because in Britain they call it tetracositrin. But it's the cosentropin is a synthetic fragment of ACTH that's biologically active. If we're not sure, we can give you a stimulation test where we give you a shot of this. It's like 1,000 times more than you ever possibly could make. And pedal to the metal, how much can the adrenal make? And if it makes more than 14, that's normal, all right? So that's kind of how we approach the situation. Now, I have to say that I haven't done a cosentropin stimulation test to diagnose adrenal insufficiency in, 25 years, because I usually get the answer crisply from the first morning labs, either once or repeating it once more. Now, okay, so you don't just get adrenal insufficiency like you get the common cold or, a wart or things like that. There has to be a reason why you have adrenal insufficiency. And so the Endocrine Society Clinical Practice Guidelines recommend, in children, we're always thinking about genetic problems like 21-hydroxylase deficiency, so we go a slightly different algorithm for them. But in adults, we usually suspect autoimmune, right? So we measure these 21-hydroxylase antibodies. Now, why 21-hydroxylase antibodies? Because the adrenal is the only tissue in the body where you make 21-hydroxylase, okay? So it's uniquely adrenal, okay? So that's why the 21-hydroxylase antibodies, and there are good antibodies to 21-hydroxylase. There are good ways to measure it, let's put it that way. So now, if that's positive, let's see, does my pointer show up? No. Okay, so if that's positive, then it's an autoimmune condition. If it's negative, you have to start thinking about other things like infections or something called adrenal leukodystrophy. Now, for the purposes of this group, if you have APS1, you might already have those 21-hydroxylase antibodies measured, right? You know, I think a lot of people will have those assessed before there is a clinical suspicion, because it is highly, Dr. Campy's group, among others, have shown that it's highly predictive in APS1 patients for the development of adrenal insufficiency. But it doesn't say when you're going to get it, all right? And so, you know, if someone, so you can have a situation which we don't normally encounter amongst this group of patients where you know they have 21-hydroxylase antibodies, and you measure a cortisol and it's normal, but you measure an ACTH and it's high, all right? Then what does that mean? Well, that means probably things have started, okay? And I don't think, I know Dr. Campy may talk about this in his talk, we don't totally know what to do in those people other than watch them carefully, because, you know, they are showing some indication that there is some adrenal failure starting in them. So again, in this group, we're really focusing on this arm of the decision tree. All right, so let's say we made the diagnosis, cortisol is very low, ACTH is very high, 21-hydroxylase antibodies are positive. How do we treat these people? So remember, there's actually 3 zones of the adrenal cortex. We already talked about aldosterone and cortisol and DHEAS. We typically don't replace the DHEAS. There's some controversy about that. I'm not saying it's wrong to do. It's just that there isn't a pharmaceutical preparation of it that we have available to us. And yeah, usually if people aren't feeling well, you're not adjusting the other medicines, right? That's usually not the DHEAS. Okay, so the cortisol, we use hydrocortisone to replace that. Now, what is the difference between cortisol and hydrocortisone? Well, they're the same thing, actually. It's just that when it was used as a drug, we first had cortisone. So when cortisol became available, because people were used to using cortisone, we called it hydrocortisone, so people recognized what it was, okay? But it is cortisol. It's replacing exactly what you normally make. And the maintenance dose, well, we used to say 10 or 12 milligrams per meter squared per day. Newer studies suggest that the daily production rate is actually a little less than that. It's probably more like 6 to 8 milligrams per meter squared per day. So we're talking for most average sized people somewhere between 10 and 20 milligrams a day. When I was a fellow, it was 30 milligrams a day. And now we've been doing mostly 20 milligrams a day. And now we're starting to use 15 milligrams a day in a lot of people. So cortisol is very tricky because none is bad, too much is bad, and a flat line is bad, okay? So what you want to have is a high peak in the morning, a little bit later in the day, but none overnight. That's sort of a physiologic replacement. And to do that with hydrocortisone, we usually have to give 2 doses, higher dose first thing in the morning, and I always say on horizon. So, you know, the pill bottle may say 8 a.m. because that's what the electronic medical record gives you the option for. But, you know, if you get up at 6, you take it at 6. If you sleep late on the weekend and you get up at 10, you take it at 10. You don't wake up at 8 o'clock and then try to go back to sleep after taking your hydrocortisone. So you take the first dose on horizon. And then the second dose, you know, I usually tell people after lunch. In England, they tell them at tea time, you know, they have tea at 3 o'clock. But you know, it's around 2 o'clock in the afternoon for the second dose. So its standard regimen will be 10 in the morning, 5 in the early afternoon, or 15 in the morning, 5 in the early afternoon. Those are kind of standard regimens for people. But then we clinically titrate. Some people may want to and do better if they distributed 3 doses, and that's fine. But we don't want that last dose at bedtime. We want it earlier in the day because, again, we don't want it peaking when you go to sleep. There's no purpose for cortisol. It just keeps you awake. So that's the sort of thing, circadian pattern. And then Dr. Canby will go in great detail about sick day rules. Basically, anytime you're losing fluids faster than you can replace them, you have to at least double your dose. And I'll let him discuss that in more detail. Now, what are options other than that? Well, a lot of people use prednisone. I actually don't like prednisone as a drug because it's actually like cortisone. It's not the active drug, it's a prodrug. It has to be metabolized by the liver to prednisolone, which is the active form of the drug. So I generally will use either prednisolone or methylprednisolone as an alternative. Methylprednisolone is widely available and cheap. It's the generic of Medrol. And that you can usually get away with 1 dose in the morning, and that's it. About 4 milligrams, maybe 6 milligrams. But it does have a tendency to cause adverse effects because it's longer acting than hydrocortisone. And then dexamethasone in adrenal insufficiency, I don't think it's really a good idea for chronic use. I'm fine with it for short-term use. Sometimes people will use that for their sick day replacement. There are pros and cons of that. It has a longer half-life, but it doesn't have any salt-retaining activity. So I generally try to avoid dexamethasone except for specific situations. And then fludrocortisone acetate, which is what we used to call Florinef. There is no Florinef anymore. It's just the generic stuff. And it only comes in the US in 0.1 milligram tablets. And this is used for primary adrenal insufficiency. And I think the biggest mistake that most adult endocrinologists make in treating adrenal insufficiency is not paying enough attention to the mineralocorticoid. And I'll go into detail on the next slide. And then the question of DHEA replacement in women. So for APS1 patients, they are going to have primary adrenal insufficiency. They're going to need both cortisol and aldosterone replacement. So something like hydrocortisone and fludrocortisone. Now, how do we titrate these medications? Well, so I can't measure one lab value and tell you everything is perfect. Okay, so when we're giving thyroid hormone, again, with the thermostat, the thyroid is controlled by a pituitary hormone called TSH. We measure a TSH. And if that's normal, your replacement is good. Okay. The problem with cortisol is that no matter how much we give, it's very hard to normalize the ACTH. And we don't really know why that is. So we actually don't follow ACTH. We don't use that as a measure. So we look for over-replacement by people having signs of what we call Cushingoid features, things that are due to cortisol excess or glucocorticoid excess of any type, people taking prednisone for arthritis or people who have endogenous Cushing's disease. So what do? They get weakening of their skin, muscles, and bones. So they get bruising, stretch marks that are purple, they get skin thinning, and they get this fat redistribution around their head and neck. And they also get muscle weakness, particularly in the proximal muscles. Now that's over-treatment. Under-treatment is if they're losing weight or having at least anorexia, not feeling like eating, or afternoon fatigue, they might not be getting enough of their second dose. And the dose distribution, like I said, is a little bit of trial and error. So if they don't have any signs of underdosing or overdosing, then we just sort of work with them empirically on the dose distribution. But one of the nice things about using hydrocortisone is that it is cortisol. And if I have a question, like let's say there's some enteritis, right? So there's some inflammation in the bowel. Are you getting good exposure to it? Well, I can measure a cortisol level, right? And if I want to measure a peak, I measure it 1 or 2 hours after the dose. And if I want to measure a trough, I measure it before your afternoon dose, okay? So usually I'm interested in how long it's lasting. So we'll sometimes have people come to the lab in the afternoon before they take their second dose and have a cortisol measured if I'm concerned that they're not getting enough. Now, the mineralocorticoid, the fludrocortisone, standing blood pressure, every adrenal insufficiency patient in my clinic gets a standing blood pressure and heart rate every visit. And the nurses won't do it, so I have to do it myself. And then, everybody's nodding here. So I want their serum potassium not high because it also controls the potassium, and I want their plasma renin not high because, again, that's the kidney telling me, hey, we're volume depleted, we need more volume, we need more salt and water, we need more fludrocortisone. So again, I think that this is one of the things that adult endocrinologists in particular don't pay enough attention to. If people have chronic fatigue and they take their hydrocortisone and it doesn't improve, it's probably not enough fludrocortisone. It's probably that they're chronically living with low blood pressure, and that's why they're tired all the time. They say, I wake up fine, and then I go through the day, and I take my hydrocortisone, it doesn't help. I go through the day, and I get tired. I just can't keep going. That's usually what it is. All right, now, there are some new forms of hydrocortisone. This is called plenidrin. So the 3 peaks here is when you give 3 times a day hydrocortisone. And then the plenidrin has an immediate release outer layer and then a slow release inner layer. And so with one dose, you kind of average out what the kinetics of the 3 doses are. So that's pretty good. It's not available in the United States. It never really caught on in Europe very much, except for a few countries, and I'm not totally sure why about that. And then the last thing is a modified release form, which is called FMODY, EFMODY, which is a cutesy little name that the company came up with. And in the US, it's going to be called Chronocort. It's in trials now in the US. And it has a core, and then the hydrocortisone, and then they experimented with different sustained release layers underneath an enteric coating. So the enteric coating means it doesn't dissolve in the stomach. It waits until it gets into the intestine before the pills dissolve, and then it releases the hydrocortisone. And so what you do with this is you take it at bedtime, and then there's a delay before it's absorbed. So it's not like prednisone. Prednisone or prednisolone, it peaks immediately, but then it has a slower decline than hydrocortisone. This has a lag before it's absorbed. So remember I said 1 or 2 hours is when you get a peak from the immediate release hydrocortisone. This doesn't peak until about 6 hours, okay? And then it has sort of a flat area here, and then it comes down gradually. So in theory, by taking this medicine at bedtime, it will start to rise at the time when cortisol is normally rising, hang out for a while, and then gradually decline in the evening. So I think that's all I want to talk about today. So I think, are we going to hold questions to the end?
Yeah, that's
okay. All right. So then I will end this escape.
Thank you.
Okay, great.